Good morning. So today we are going to see the drug metabolism. We have already seen that from the site of administration, drug reaches to the circulation. This is known as drug absorption. Once it reaches to the circulation, it is delivered to the different tissues. That is drug distribution. Sometimes from one tissue, it is delivered to another tissue, that is redistribution. Now the drug reaching to its site of action, performing its action and whatever beneficial effects we desire. At the same time, the drug can also produce harmful effect also. But once the job of the drug is over, we need that it should be removed from the body. So the removal of the drug from the body is drug excretion or drug elimination. Now, many times it is difficult to remove the drug in the same form as it has been absorbed. So we need some changes in the drug form. These changes are known as biotransformation or metabolism. So today we are going to see the drug metabolism. What is this metabolism? What are the various enzymes involved in this metabolism? What are the steps of metabolism? What are the factors that affect the process of metabolism? So that is the target for the today's session. So metabolism, it is the enzyme mediated conversion of a chemical to another chemical. So enzyme mediated conversion of drug to another drug, that is metabolism. The biochemical mechanism that converts the drug into a polar and water soluble compound, this is biotransformation or metabolism. So here the drug is converted into a polar, that is the charged or ionized and water soluble compound. This process occurs with the help of enzyme. So enzymes are involved, and this process is to help the elimination of a drug. There are few drugs which are eliminated as such. For example, volatile general anesthetics, aminoglycosides like gentamicins, etc. In most of the cases, the metabolism leads to inactivation. So it inactivates the active component, that is a drug. Sometimes it activates the drug. So the drug which is used in an inactive form, that get converted into active form in the body, that is known as pro-drug. For example, we are using levodopa in Parkinsonism, that is converted into the active form dopamine, that is effective. Some metabolites retain the parent activity. That means they are as active as the parent component is there. So both are active, drug as well as metabolite. Occasionally, the drug is converted into a more toxic form. So in this case, the metabolite that is more toxic than the parent component, for example, methanol, that is converted to formaldehyde. This is toxic much more than methanol. Paracetamol, that is converted into a reactive intermediate, that is also toxic to the liver. So we have seen that metabolism is to help in the elimination of the drug. it may inactivate the drug. Sometimes there is activation of the drug. Sometimes the parent activity is retained and sometimes it may convert it to a toxic component. The major site of metabolism is the liver. Beside liver, there can be some extrahepatic sites such as kidney, for example, vitamin D, from GIT, like penicillins, insulin. Lungs also play a role in the metabolism of IST. In plasma, there are some enzymes, for example, esterase, metabolize succinylcholine. In the skin, the conversion of 7-dehydrocholesterol to cholecalciferol, that is vitamin D3, that is occurring. Placenta also metabolizes many drugs reaching to the fetus. The enzymes in the metabolism could be cellular or extracellular. Cellular enzymes are microsomal or non-microsomal. Microsomal enzymes are present in endoplasmic reticulum. Gluconide conjugation and most of oxidation takes place by microsomal enzymes. Non-microsomal enzymes, they are present in cytoplasm and mitochondria. All the conjugation except gluconide and some of oxidation take place by these enzymes. Reduction and hydrolysis takes place by both microsomal as well as non-microsomal enzymes. There are also extracellular enzymes which are non-microsomal. For example, esterase in the plasma, hydrolase in intestinal fluid. So various enzymes, cellular, extracellular, microsomal, non-microsomal. Now, how the metabolism takes place, the pattern of metabolism. It may take place in two phases. Phase 1 reaction that usually convert the parent drug to a more polar metabolite by introducing or unmasking a functional group. For example, hydroxyl amino thiol group by the process of oxidation, reduction, and hydrolysis. Metabolites so produced are either excreted as such or undergo a subsequent synthetic reaction. Phase 2 reaction, that is synthetic or conjugation reactions, where coupling between the drug or its metabolite and an endogenous hydrophilic substances like gluconic acid, sulfuric acid, etc. These reactions are to create more polar conjugates so that drug becomes more lipid insoluble. So it is now highly water soluble. So it gets excreted easily. All conjugate products are pharmacologically inactive except morphine gluconide, which is more active than morphine. Types of phase 1 reaction. Oxidation, that is incorporation of oxygen or removal of hydrogen. Most of oxidation is carried out by microsomal enzymes like cytochrome P450, FMO, that is flavin containing monooxynase, and EH, that is epoxide hydrolase. Examples of microsomal oxidation are N and O dealkylation that converts codeine to morphine, hydroxylation, that is introduction of an hydroxyl group, for example, phenobarbital, S oxidation of phenothiazine, N oxidation of paracetamol, deamination of amphetamine, desulfuration of thiopental, epoxide formation of carbamazepine. Non-microsomal oxidation examples are alcohol and aldehyde by dehydrogenase, 6-mercaptopurine by xanthine oxidase, catecholamine by monoamine oxidase, and decarboxylation of levodopa to dopamine. So they are the examples of the oxidation process, microsomal as well as non-microsomal. Another phase 1 reaction is the reduction, where there is addition of hydrogen or removal of oxygen. Both microsomal as well as non-microsomal enzymes are involved. For example, azo reduction of pentosyl to sulfonamides, nitro reduction of chloramphenicol, dehalogenation of halothane. That is hydrolysis, where there is addition of water molecule, example esters like procane, hydrolyzed by esterase, amides like propanamide, and lidocaine by amidase, epoxide hydrolysis of carbamazepine epoxide. The major enzyme involved in this process, that is cytochrome P450, more than 2/3 drugs are metabolized by cytochrome P450, that is CYPs. There are a number of different subtypes and their subtypes named with the root CYP followed by a number denoting the family, a letter that denotes subfamily, and another number that denotes CYP form. For example, CYP3A4, that is family 3, subfamily A and gene number 4. This is the most abundant form involved in metabolism of more than half of the clinically used drugs. Next common form is CYP2D6. CYPs in drug metabolism are non-specific in the A particular CYP may catalyze number of drugs and multiple enzymes may metabolize a single drug. Two drugs metabolized by same CYP may compete with each other, leading to inhibition of the metabolism of one or both. CYPs also catalyze synthesis of endogenous substances, for example, steroids, bile acid. Here they are specific for a particular substrate. For example, aromatase, that is CYP19A1, that is specific to form estrogen from testosterone. Besides cytochrome P450, the other enzymes involved in the oxidative process are FMOs and pH. FMOs, that is flavin containing monooxygenase, they are most abundant out of the 6 recognized families. FMO3 is the most abundant form. It metabolizes nicotine, H2 blockers, clozapine, etopride. FMOs are neither induced nor inhibited, so no drug-drug interaction. This is why etopride is not involved in drug interactions as are observed with cisapride, which is metabolized by CY3F4. Epoxide hydroxylase that deactivate the potentially toxic derivative epoxide generated by cytochrome P450. Carbamazepine is activated to its epoxide form by CYPs, which is then deactivated by microsomal EH. This EH is inhibited by valproic acid and hence the concentration of carbamazepine gets increased. Then there is phase 2 reactions, which are also known as synthetic or conjugation reactions. Coupling between drug or its metabolite and an endogenous hydrophilic substrate. This is the synthetic reactions. These reactions are to create more polar conjugates by enhancing the hydrophilicity. So drug becomes more lipid insoluble, more water soluble. The types of conjugation reactions and their clinical significance. Just we can get an idea that gluconide conjugation. This gluconide enters, that is secreted in the bile to the intestinal tract, from where that is broken down, the active drug again released free, that gets absorbed and that re-enters in the circulation. This is known as intrahepatic recirculation. Examples are morphine, estrogen. Then there is glutathione conjugation. Glutathione conjugation protects cells from the damaging effect of reactive metabolites. When we use overdose of paracetamol, or if patient is having hepatic insufficiency, deficit of glutathione, the metabolite of paracetamol become toxic to the liver cells that can lead to the damage to the liver. Sulfate conjugation, there can be the formation of the chemically reactive metabolite as we have seen with the paracetamol, which is leading to a reactive metabolite that is toxic to the liver. Glycine conjugation, the drug get conjugated with glycine, there is limited availability. So in high dose, this drug will follow zero order kinetic. Example we know that is aspirin. Acetylation, drug may get acetylated. There are two types of genetic variants, slow and rapid acetylator. There is increased potential for toxicity in slow acetylator. That could be SLE, systemic lupus erythematosus. So SLE could be observed in the slow acetylator of sulfonamide, hydralazine, isoniazide, procainamide. Then the next conjugating process is methylation, where in some patients where there is genetic deficiency of a particular methyl transferase, that can lead to severe toxicity, for example, in case of mercaptopurine. So they are the phase 2 reactions and their clinical application. Now, let us have an idea regarding the factors that affect the metabolism. So metabolism could be affected by age. At both the extremes of the age, metabolism get reduced. The very young age, the metabolic machinery is not well developed, and at very old age, the machinery get exhausted. Diet. Enzymes are protein in the nature, so hence, if there is deficiency of the protein, naturally the metabolic process will become slow. Route of administration. With oral route, hepatic first pass metabolism can reduce bioavailability of the drugs like morphine, testosterone, nitroglycerin. So this can be avoided by using such drugs with other routes. Since these drugs get extensive hepatic first pass metabolism during their access to the liver, therefore, and this is the reason why there is difference between the oral and sublingual dose of these drugs. Presence of other diseases can also affect the process of metabolism. Naturally, we can understand that metabolism is reduced in liver disease, cardiac disease, hypothyroidism. In kidney disease, the toxic metabolites of some drugs get accumulated and they can produce toxicity. For example, norepinephrine, a metabolite of pethidine that can produce seizures or convulsions. Enzyme induction. A few drugs stimulate synthesis of metabolic enzymes that speeds the metabolism of different drugs to reduce their effectiveness. These drugs are referred as enzyme inducers. So enzyme inducers increase the metabolism of various drugs metabolized by the same enzyme, and they can reduce their effectiveness. Examples of enzyme inducers are barbiturates, phenytoin, carbamazepine, rifampin, griseofulvin, chronic alcohol, efavirenz, nevirapine, and John's wort. The drugs affected are the drugs themselves, that is autoinduction, oral anticoagulant, oral antidiabetic, oral contraceptives, steroids, lidocaine, quinidine, statins, cyclosporine, tacrolimus, protease inhibitors, vitamin D, and vitamin K. In a case where the metabolite is toxic, the enzyme inducer can enhance the toxicity. For example, chronic intake of alcohol enhances toxicity of paracetamol. The pattern of enzyme induction is not same for all inducing agents. Phenobarbital non-selectively stimulates many microsomal enzymes. Ethanol produces selective effect on CYP450A1. In contrast to enzyme induction, there is another term that is used, enzyme stimulation. Enzyme stimulation is the activation of the enzyme activity. It can be stimulated by substrate stabilization, which is achieved by inhibiting its degradation. For example, CYP2E1 that is stabilized by ethanol. This property of enzyme induction is sometimes used to manage some clinical problem, and it also becomes contraindication in few conditions. So enzyme induction as therapy is used, for example, phenobarbital that induces gluconide transperases which metabolize bilirubin. Hence, it is indicated for a high-risk pregnant woman such as Rh incompatibility. Here it will reduce the risk of hyperbilirubinemia and kernicterus in neonates. Enzyme induction as contraindications. The enzyme induction stimulates synthesis of delta aminolevulinic acid synthetase that increases porphyrin synthesis. So it leads to a precipitation of a severe attack of porphyria in patients with intermittent porphyria. Here there is demyelination of the nerves leading to pain, weakness, paralysis, and death. Therefore, all potent enzyme inducers are contraindicated to a patient of porphyria. Just as we have seen the enzyme induction, there are drugs which can inhibit the enzyme synthesis. So enzyme inhibitors like chloramphenicol, cimetidine, phenylbutazone, erythromycin, clarithromycin, ketoconazole, itraconazole, ritonavir, levudiran, and grapefruit juice, they all inhibit the metabolism and they can increase the risk of toxicity. As we have seen that with terfenadine and estamazole, there is risk of tarsus d pietis. It is a form of ventricular arrhythmias. So this problem occurs if terfenadine or estamazole is used with potent enzyme inhibitor like erythromycin and ketoconazole. And this is the reason why these drugs have been removed from the market. There is increased risk of nephrotoxicity by cyclosporine, tacrolimus. The risk of myopathy and rhabdomyolysis by statin, that is also increased in presence of enzyme inhibitor. Rhabdomyolysis, that is the dissolution and disintegration of the muscles. Omeprazole is inhibitor to CYP2C90, so inhibits activation of clopidogrel. So clopidogrel can become less effective in presence of an enzyme inhibitors like omeprazole. Enzyme inhibitors are also used in therapy to achieve therapeutic level with low doses. For example, ritonavir is used with various other protease inhibitors. So co-formulation of a protease inhibitor with ritonavir, that is based on these facts that a therapeutic level, higher therapeutic level could be achieved with low doses. Then there are some other factors which can affect the metabolism. For example, pharmacogenetics. That is the genetic variations. We know that succinylcholine, that is a muscle relaxant that is metabolized by pseudocholinesterase present in the plasma. Some patients, they are deficient with this enzyme, so there is extensive effect of succinylcholine leading to the muscle paralysis of the respiratory muscles that will stop the respiration. So this condition is succinyl apnea. That is the example of genetic variation mediated response. Intestinal microflora, if that gets disturbed, that produces deficiency of reductase, so that reduces metabolism of some drugs. Intrahepatic recirculation, we have already seen that gluconide conjugate rapidly secreted in urine and bile. It is hydrolyzed in the intestine and free drug reabsorbed. This is intrahepatic recirculation that prolongs the duration of action of such drugs like estrogens, morphine, chloromethane. So excess use of antibiotics that can disturb this process, and there can be ineffectiveness of these drugs. Environmental factors, for example, exposure to chlorinated insecticides and bench firing with cigarette smoking and charcoal burning enhances the metabolism of drugs like theophylline, pentazocine, dipropoxyphene, etc. So we've seen what is metabolism, what are the different phases of the metabolism, what are the different enzymes involved in the metabolism, and what are the factors that can affect the metabolism.